Let's look at a very important review entitled Effectiveness of Manual Therapies, the UK Evidence Report. This is a very comprehensive review and rating of manual therapy approaches based on reviewing which therapy for which condition, not on which manual therapy practitioner. It covers well the current literature up to the point of publication in 2010. Noteworthy are the authors stellar in the world of chiropractic research, including Gert Bronford, Mitchell Haas, Ronnie Evans, Jay Triano, and Brent Leininger. Also noteworthy is that the publication is in a peer-reviewed online journal with free access, Chiropractic and Osteopathy. This journal is indexed in Index Medicus and therefore is listed in PubMed searches. So why now? This effort was commissioned by the General Chiropractic Council, the chiropractic regulatory body in the UK. This was related to a libel suit involving Simon Singh, a science journalist, as a result of an article he published in the Guardian newspaper. The title of the article was, "Beware the Spinal Trap." In the article, Singh expressed concerns about practitioners who use cure-all claims in advertising. He was critical of the British Chiropractic Association for allowing this type of advertising on their website. He also implied that given there is no scientific evidence to back up such claims, they or the General Chiropractic Council should sanction chiropractors who make such claims and, by a lack of sanction, infer acceptance or promotion. The statement that particularly set off the libel suit was that the BCA, quote, happily promotes bogus treatments. He claimed that the BCA announced that their members can help treat children with colic, sleeping and feeding problems, frequent ear infections, asthma, and prolonged crying. In fact, there are no claims on the current website, but Singh's claim was that it was present in 2008. The current description on the BCA website about what chiropractic is and does is well done and focuses on joints, muscles, ligaments, and nerves, and makes no statements about optimal health or treatment of non-musculoskeletal conditions. Well, for those of us in the US, this all seems a little, well, foreign. But in the UK, it's far more common for some chiropractors to run radio and TV ads regarding treatment of non-musculoskeletal conditions, making claims that have never appeared in US advertising, at least not on the radio or TV. Viewed from a broader perspective, Singh and well-known CAM critic Edzard Ernst, MD, wrote a book entitled Trick or Treatment: Alternative Medicine on Trial. As usual, Ernst in particular takes out of context and with cherry-picking to his bias the scientific evidence to suggest not only that chiropractic was ineffective, but dangerous. He clearly does not understand or want to understand the evidence that is available. On the chiropractic side of the issue, it may be that chiropractors who make these claims are well-meaning and based on their own individual experience, they believe they are providing a much-needed service. The concern by scientists, though, is that the practitioner cannot discern among three possibilities due to the inherent bias of practice. Well, these are overlapping with natural history. In other words, it would have gotten better anyway, and the patient happened to be involved with treatment that coincided with that success. Secondly, the placebo effect. And, of course, the possibility that the therapy actually works. Well, back to the purpose of this presentation, the review of manual therapies. How did they approach such a huge endeavor? Well, these are researchers who have participated in previous reviews and were well acquainted with the current literature. Nonetheless, they proceeded as always with a very careful literature search, used a well-accepted rating system, and based recommendations on a clinician-friendly scale. So let's start with a summary of the ratings, and then we'll continue with a more in-depth overview of approaches and actual recommendations. Using their rating scale, evidence was determined to be either inconclusive, moderate, or high, and further categorized by whether it was positive regarding the therapy, negative, favorable, or not. So here's the quick summary for high and moderate positive ratings for manipulation or mobilization. These include acute, subacute, and chronic low back pain, migraine and cervicogenic headache, cervicogenic dizziness, several extremity joint conditions, thoracic manipulation or mobilization for acute or subacute neck pain. Here's the list for those conditions under inconclusive evidence. These include cervical manipulation or mobilization alone without exercise for neck pain of any duration, mid-back pain, sciatica, tension-type headache, coccydynia, TMJ disorders, fibromyalgia, premenstrual syndrome, and pneumonia in seniors. For conditions where spinal manipulation was rated as not effective, these include asthma and dysmenorrhea when compared to sham manipulation, and stage 1 hypertension when compared to an antihypertensive diet. A separate listing for children indicated the evidence was inconclusive for otitis media and enuresis, and ineffective for infantile colic and asthma. There's more to this picture, though, as we'll see. So what does manual therapy mean in this study? Well, manual therapy in the study includes manipulation, mobilization, massage, and exercise, but other treatment approaches were acupuncture, friction massage, trigger point therapy, self-mobilization, yoga, reflexology, cranial osteopathic technique, orthosis, braces, heat, and electromodalities. It was a very stringent process used in rating the literature, which included a hybrid approach that was used by the U.S. Preventive Task Force and a grading system similar to the 2007 Joint Clinical Practice Guidelines on Low Back Pain published by the American College of Physicians and American Pain Society. Now, this was used for previously evaluated RCTs and reviews. Here are some examples. Please pause if you wish to review further the criteria listed for each. An approach they borrowed from the Cochrane collaboration for new RCTs is a risk of bias assessment tool. Here's an excerpt from that rating tool. You can see by the judgment column that these are attempts at detecting bias due to obvious features such as lack of randomization, blinding, study sample size, and biased interpretation of findings. And here is the interpretation scale used. A high risk of bias rating indicates a lower quality study, whereas a low risk of bias rating equals a higher quality study. In reviewing the results of this rating approach, it must be noted that although there will be accusations that the reviewers were biased due to their affiliation to chiropractic, it's noteworthy that only one therapy approach for one condition received the highest rating, and that there are many condition-based treatments that were rated as negative. Bias does not seem to be in play here. What's different between this review compared to the many reviews published over the last few years? Well, this is in large part the work of Jay Triana, who developed an approach to directing clinicians in how to apply the recommendations in their practices. Now, there are two applications to consider. One is making public claims, and the other, the individual patient recommendation. This involves using a rating system tied to recommendations for what should and should not be publicly advertised, and what should and should not be said to patients, and what alternatives there may be in questionable scenarios. Except for high and moderate ratings, all inconclusive or negative ratings have a directive to advise the patient on an effective alternative therapy if available. Unfortunately, we'll see that we are still one ingredient away from application. What's that? You. I'll explain why in a moment. Let's look at a list of conditions and specific therapies that were rated as positive at a high or moderate evidence level and remind the listener that this rating supports public favorable claims regarding effectiveness and that the clinician can advise patients that this is an effective treatment choice. Spinal manipulation and mobilization for chronic low back pain was the only condition therapy to receive a high positive rating. Under moderate positive ratings, we see acute low back pain, acute subacute neck pain, acute whiplash-associated disorders, and chronic neck pain all include spinal manipulation, mobilization, and sometimes exercise. For chronic low back pain and chronic neck pain, massage receives a moderate positive rating. There are a number of extremity disorders that have manipulation and mobilization listed under the moderate positive rating. For headache and dizziness, we also see spinal manipulation, mobilization, and self-mobilizing apophyseal glides listed under the moderate positive. So let's test out recommendations for the conditions and therapies that did not receive a high or moderate positive rating by working through 3 case scenarios that might be common in your practice. The first case is someone who's had a rotator cuff problem that has responded well in the past to manipulation by another practitioner. They have the problem again and would like you to also manipulate their shoulder. Well, if we use the report's recommendations at face value, we would need to recommend an alternative because rotator cuff pain is listed as inconclusive but favorable for the use of manipulation. Here is where logic and practitioner experience would seem to modify the application of the recommendation. Plus, based on the recommendations that there is no conservative alternative that has been shown to be effective, it might seem logical. Also, we can see in the report that for shoulder girdle problems or dysfunction, manipulation or mobilization have moderate, positive evidence for effectiveness. What if a patient had mid-back pain? Assuming there are no red flags based on these recommendations, manipulation or mobilization has been rated as inconclusive but favorable. Thoracic spine manipulation has positive evidence for shoulder and neck pain, but not for mid-back pain. It might seem odd that manipulation for mid-back pain is in the inconclusive but favorable column. This is a great example of what Martin Underwood, MD, reminds us of in a commentary on this report. Quote, absence of evidence of effectiveness is not the same as evidence of absence of effectiveness, unquote. It's likely that given it's such a common complaint and treatment approach, there simply is little research devoted to this area, especially in RCT. Here's a more difficult third case scenario. What if a patient had heard you might be able to help them or their child with their asthma? Well, did they arrive to this conclusion because of advertising? Let's apply the recommendations and illustrate one approach to interpretation. Instead of advertising that chiropractic will cure asthma, it would be more appropriate to not advertise anything regarding asthma and simply answer any questions posed by a patient regarding asthma, and to give the literature recommendation from this review, which includes that osteopathic manipulation has a favorable yet inconclusive rating. Manipulation or mobilization has a moderate negative rating, though. Standard medical options should be recommended, but what if they've tried these and they're not effective? The clinician should give their individual, honest expert opinion with some examples from their own practice if they have any. This would also require that the clinician be entirely familiar with the confounding factors that might cause one to misinterpret success, and frankly, in some cases, a more intimate knowledge of the results of the literature. For example, with the asthma issue, the publication by Ballin et al., a comparison of active and simulated chiropractic manipulation as adjunctive treatment for childhood asthma, published in the New England Journal of Medicine, indicated that manipulation, in addition to standard medical care, was not effective, as this review states, when compared to sham manipulation. What's interesting is that many subjective improvements do occur for both the real and sham manipulated patients, such as a decrease in symptoms, beta agonist medication use, and an improved quality of life. This could be conveyed to patients so that they might understand that improvement may in fact occur, but the reason for that improvement is unclear but does not appear to be directly related to the chiropractic manipulation. Another approach might simply be to treat the patient for any spinal issues that may be present and explain that sometimes patients feel improvement in apparently unrelated areas. So it appears as though the recommendations from the UK report have some value, but we have several hurdles and implementation issues to overcome. First and foremost is that, as I stated at the beginning of this overview, this review was based on the therapy, not the practitioner. So it's important to understand that manipulation or mobilization, and certainly any of the other therapies, may have been performed by manual therapists other than chiropractors. This then isn't a question about what chiropractic technique, it's more the question of what is meant by manipulation. Simply put, you won't know until you read the articles reviewed by these researchers. Some may surprise you because they are not standard chiropractic versions of a particular regional adjustment, and some are. More confusing might be the recommendation for cervicogenic headache and dizziness regarding self-applied apophyseal glides, which were given a moderate positive rating. These are based primarily on a group of techniques, sometimes referred to as the Mulligan technique. The specific ones being referred to in this review are called SNAGs, which stands for Sustained Natural Apophyseal Glides. Unless you read the full report and references, you would not have known that. If you are not trained in that technique, how would you learn? We're going to deviate for a moment to show you how. The reference for this is from the periodical Journal of Orthopedic and Sports Physical Therapy and is listed in the report. It turns out this is accessible free of charge online. Let's go to it now. Let's watch the short video and I'll explain how this self-administered treatment is applied. The patient is using elastic tubing. It's applied across the posterolateral C1 process. As tension is applied forward horizontally, the patient turns their head to the side of restriction, which in this case is on the right. They follow through with that, sustaining the pressure. Maintaining the pressure, they return back to the neutral position. Another difficulty is directly applying the recommendations for exercise. Let me point out that for a number of disorders, manipulation and mobilization with exercise is rated more effective than manipulation or mobilization alone. These include acute whiplash, chronic neck pain, tennis elbow, knee osteoarthritis, and patellofemoral pain, and plantar fasciitis. The specific exercise or exercise program is not evident in this review. Some of you are probably familiar with the recommendation for exercise for the deep neck flexors for neck pain, but again, this is not obvious in this review. Again, it will vary from study to study, but I would recommend accessing the articles in the UK evidence report to get more specific descriptions of exercises or protocols. As a summary, the UK evidence report is an extremely important document that all practitioners should be clinically familiar with. This requires taking the recommendations and applying them whenever possible. It's also requiring a more in-depth review of the literature utilized in this report to determine the specifics of management application for manipulation and exercise. At the very least, it should serve as the benchmark for public claims decisions. It should guide clinicians in their discussions with patients. And for conditions that are not represented in this report or the therapies that are listed as inconclusive but favorable, a research agenda should be developed.